This is a recording of the virtual class on electrophysiology catheter ablation procedure, what to expect at the University of Ottawa Heart Institute. My name is Anne, and I'm a registered nurse. This class is to prepare you for future procedures and for patients who want to learn more about the ablation procedure. In this class, we will discuss the heart's electrical system. We will build some understanding on different heart arrhythmias and what to expect before, during, and after the ablation. The heart consists of 4 chambers, 2 upper chambers called the atrium and 2 lower chambers called the ventricle. The heart is a muscle that works like a pump, and its main job is to pump the blood throughout the body in a closed system with the lungs. Blue blood, or blood with carbon dioxide, is returned to the right side of the heart through the veins, where it is pumped to the lungs. Blood drops off carbon dioxide, which is then breathed out. Blood picks up the oxygen, which has been breathed in, and returned to the left side of the heart, which pumps the blood out of the body through the arterial system. The pumping of the heart is regulated by an electrical current or impulse, like a spark plug in a car. Electrical impulse starts in the sinoatrial node, or the heart's natural pacemaker, and spreads through the right atrium and over to the left atrium like a ripple in a pond. This causes the muscle of the atria to contract and pump the blood into the ventricles. The impulse then travels down the atrioventricular node, or the junction box, and through the bundle of hisses to the ventricles via the right and left bundle branches. This causes the muscle of the ventricle to contract and pump the blood to the lungs from the right side of the heart and to the rest of the body from the left side of the heart. This is how a heart beats effectively. You may find more information on this in our complex ablation and standard ablation booklets available on our website. Heart arrhythmia. An arrhythmia is an abnormal heart rate or rhythm that occurs when there's a problem with the heart's electrical system. 2 terms to be familiar with are electrophysiology study and ablation. Electrophysiology study is a specialized procedure done for certain types of arrhythmias to help pinpoint the source of the abnormal rhythm. They use electrophysiology catheters to map and evaluate the electrical activity inside the right atrium. They use electrical pulses to stimulate the arrhythmia. Ablation is an application of a source of energy, hot or cold, to create a scar line in the abnormal cells that cause the arrhythmia, thereby stopping it. Some people may have supraventricular arrhythmias. The word supraventricular means above the ventricles. Therefore, the arrhythmia starts somewhere in the upper chambers, the atria. Supraventricular arrhythmias include supraventricular tachycardias, or SVTs, atrial fibrillation, and atrial flutter. These arrhythmias are usually not life-threatening, but can disrupt regular blood flow throughout the heart and make you feel unwell. Some symptoms may include rapid or fast heart rate, palpitations or thumping in your chest, dizziness, lightheadedness. Some patients may experience chest pain or chest tightness, and some people have no symptoms at all. There are 3 types of SVTs, or supraventricular tachycardia: atrial ventricular nodal reentry tachycardia, atrial ventricular reentry tachycardia, or Wolff-Parkinson's-White, and atrial tachycardia. Sometimes your arrhythmia specialist knows what type of SVT you have based on your electrocardiogram, and sometimes they do not know what type of SVT you have. And you will require an electrophysiology study to pinpoint the source of the arrhythmia prior to your ablation. AV nodal reentry tachycardia occurs when there's an electrical impulse that gets caught in the extra fibers around the AV node and starts rapidly circulating the AV node. This causes a rapid heart rate. atrioventricular reentry tachycardia, or Wolff-Parkinson's-White. People were born with an extra electrical pathway between the atria and the ventricles and completely bypasses the normal AV node pathway. When the electrical impulse goes through the extra pathway, this causes periods of very rapid heartbeats. Atrial tachycardia is when the electrical impulse starts somewhere in the atria other than the sinoatrial node. This causes abnormally rapid heart rates from 100 to 250 beats per minute. Atrial fibrillation is caused by an electrical short circuit originating around the pulmonary veins, causing the upper chambers to quiver rather than contracting normally. Atrial fibrillation ablation targets the pulmonary veins in the left atrium. A scar line is burned using a special catheter to fence the electrical short circuit. This procedure is not a cure. Its main purpose is to reduce the number of episodes and the severity of symptoms. Success rates vary depending on the progression of your arrhythmia, but it is common to need a second ablation. Atrial flutter is similar to atrial fibrillation, but less common. In atrial flutter, the electrical impulse travels in a loop around the AV node, and this causes very rapid heartbeats. On an ECG, it's identified by its sawtooth pattern. Typical and atypical atrial flutter depends on the location of the short circuit. Typical atrial flutter is localized in the right atrium, and atypical atrial flutter is localized in the left atrium. People have ventricular arrhythmias. Difference between supraventricular arrhythmia and ventricular arrhythmia is that the ventricular arrhythmia occurs in the lower chambers of the heart, called the ventricles, the main pumping chambers. PVCs, or premature ventricular contractions, are single beats coming from the ventricles. This is when you have less than 3 of these beats in a row. PVCs usually do not need treatment unless patients are very symptomatic. When you have more than 3 beats, it's called ventricular tachycardia. VT, or ventricular tachycardia, can be dangerous because the heart beats so fast, sometimes over 200 beats per minute, and blood isn't being properly pumped to the rest of the body. Symptoms include extreme dizziness, fainting, and sometimes complete collapse. Treatment for arrhythmia. Some of you may have been prescribed medications to manage your arrhythmia, but in consultation with your arrhythmia specialist, you may have decided to proceed with an ablation, or you are considering an ablation. Understand the ablation procedure. You may have heard your ablation being referred to as standard or complex ablation. The differences are based on the type of arrhythmia, the technology used, the access site, the type of anesthesia used, and the length of the procedure. Standard ablations are used for right-sided typical atrial flutter, your SVTs, and the right-sided atrial tachycardias, and AV node ablations. Access site is the right groin. You are generally given conscious sedation for these procedures. The procedure is 2 to 3 hours long, and it is a same-day discharge. Complex ablation is used for atrial fibrillation, atypical atrial flutter, left-sided atrial tachycardias, and your ventricular tachycardias. The procedures are done under general anesthetic. The procedures are a little bit lengthier, to 4 to 6 hours long, and generally you do go home the same day, but sometimes an overnight stay is required. Your physician will let you know if he plans to keep you overnight, but sometimes it's not planned prior to your ablation. Keep in note that there are general differentiations. Sometimes the complex ablation patients do not require general anesthetic. Some standard ablation patients do require general anesthetic. Your ablation will be individualized to your special situation and as planned by your physician. Before the ablation, for both standard and complex ablation, you will receive a call from our triage office with your procedure date. You will be mailed or sent via MyChart an ablation instruction letter with all the instructions on where to go the day of the procedure, the fasting instructions, and medication instructions. If you require a pre-admission appointment, you will receive a call from the pre-admission unit to schedule your appointment to meet with the anesthesiologist and registered nurse. You will have some blood work drawn if required and any other testing completed. They will review your medication instructions, answer any of your questions. It may be helpful to bring a family member or a friend with you to take notes or ask questions. Some patients will not require this appointment and will meet with the anesthesiologist the day of their procedure. Complex ablation patients will undergo some diagnostic imaging testing prior to the ablation. A CT scan is done months in advance. The CT scan provides multiple images of your heart and its anatomy that can be combined with a special mapping system to provide 3D images of your heart and allows your physician to precisely and accurately determine your electrical pathway in your heart and identify where to ablate. No results are called to you. This is strictly in preparation for your ablation. An MRI is only ordered in specific cases, usually for ventricular arrhythmias. This provides similar images of your heart and its anatomy to be combined with a special mapping system. The transesophageal echocardiogram, or the TEE, is a special type of echocardiogram that is used to check for the presence of blood clots in your heart prior to the ablation. This is for patients with persistent atrial fibrillation, atypical atrial flutter, and some ventricular tachycardias. Paroxysmal atrial fibrillation patients do not require a TEE unless otherwise indicated by the physician. The nurse will spray some freezing or numbing medication down your throat, and you'll be given some sedation medication through an intravenous to keep you relaxed and comfortable. Then a small probe will be inserted down the back of your throat and into your esophagus, which is the tube that connects your throat to your stomach, and the tip of this probe will be aimed to take an image of the chambers of your heart to check for blood clots. This will take place 7 days or less prior to your ablation. This echocardiogram takes about 45 minutes to do, and then you will be required to wait 1 hour after the test to ensure that the sedation is wearing off. If you have obstructive sleep apnea, you will have to wait 4 hours after. You must have a family member or a friend check in with you, and they must remain in hospital while you have your TEE. They must drive you home after this test. Legally, you cannot drive home. The test will not be done if you arrive alone, which means your ablation will be canceled. You will require to fast from midnight the night before. Detailed instructions for your TEE will be provided in your ablation instruction letter. Following medications instructions carefully. Before your ablation, the doctor may start an anticoagulation medication 4 to 6 weeks prior to your procedure and also advise you to hold the day of your procedure. It is imperative that you follow these instructions. Failure to do so will result in cancellation of your procedure. Get to know the name of your anticoagulation and heart medication. The doctor may also change or hold some of your heart or antiarrhythmic medications prior to your ablation. Again, follow all instructions carefully. If you are not sure on which medications to hold, call the triage office or the physician's office for clarification. Tecta or pantoprazole. For atrial fibrillation patients, you will be started on a new medication called Tecta or pantoprazole. This medication is a proton pump inhibitor and is generally prescribed for patients with gastroesophageal reflux disease or heartburn. For the atrial fibrillation ablation patients, this will help protect your esophagus during the ablation. The heart sits right behind the esophagus, and during the ablation, heat can generate over and cause some heartburn-like damage to the esophagus. Tecta is to prevent this. If you are already on a medication for gastroesophageal reflux disease, then continue that medication as prescribed. On the day of your procedure, you will register downstairs in the main lobby at the University of Ottawa Heart Institute, then take the elevators to the first floor and follow the green hearts painted on the floor to the cardiac day unit. Please bring all of your medications in their original bottles. Once in the day unit, the nurses will get you ready, change your gown, start an IV, shave both of your groins, chest and back area, and do an assessment with vital signs and any other needed blood work. For your visitor's policy, you may have one relative or friend stay with you in the day unit. The visitor will be asked to leave during the procedure, and the nurses will call them once you're recovering. Please ensure that the nurses have your visitor's contact information prior to them leaving. The electrophysiologist should come and meet you in the day unit prior to your ablation. If they do not meet you in the day unit, they will meet with you in the electrophysiology lab prior to your ablation. Your ablation will take place in the electrophysiology lab. You will meet with a specialized teams of nurses, electrophysiology technicians, and doctors. They'll escort you into the room and assist you on the procedure table. Nurses will put ECG patches on your chest and connect you to the heart monitor. They will also put defibrillator pads, and if you're having a complex ablation, they'll put 3 mapping pads on your chest and 3 on your back. Nurses will position you in a comfortable position on the procedure table with special padding, pillows, and nice warm blankets. For standard ablation patients, your groins will be clean and with a special betadine solution, and a sterile drape will then be positioned from your chin all the way down to your toes. For complex ablation patients, the anesthesiologist will administer medications to put you to sleep, and a tube will be inserted into your throat and connected to the breathing machine. Just a couple pictures to give you a sneak peek on what it looks like in the electrophysiology lab. On the right-hand side, you see an example of the mapping images seen by your physician. For standard ablation patients, your doctor will be giving you some lidocaine, a local anesthetic or freezing medication, in your right groin area. Once frozen, he will use a small needle to access your right femoral vein and then insert a sheath, which is a small hollow tube around the length and the diameter of a pen, into your vein. This sheath allows the physician to pass electrophysiology catheters through it safely and protects your vein. It has a valve at the end, so it prevents blood from leaking out. Once the sheath is in, he will insert electrophysiology catheters through the sheath of the femoral vein and into the right side of your heart, where the heart's electrical conduction system is located. The catheters are specially positioned along the conduction system to help determine the type of arrhythmia you have and then ablate it. For complex ablation patients, it's very similar, but you are asleep and there's not going to be as many catheters. For standard ablation, the doctor will position the catheters along the conduction system using an X-ray system and the tracings on the monitor. And then they will stimulate your heart to induce or bring forth the arrhythmia. This is the diagnostic part of the procedure or the electrophysiology study. You will feel your heart going very fast. Don't be alarmed, the doctor can stop the fast heart rate just as easily as he started it. Typically, the doctor will like to hold off on giving you any sedation medication during this part of the procedure because sometimes the sedation mechanism can make your body too relaxed and prevent your arrhythmia from being induced. Sometimes the doctor can't induce your arrhythmia with pacing and will start you on a medication called Isopril. that can start the arrhythmia. Again, the arrhythmia stops by turning off this medication. For complex ablation patients, it's a little bit different. For atrial fibrillation and atypical atrial flutter, physicians know it is originating in the left atrium of the heart. Therefore, we'll directly place the mapping catheter in that chamber to map the atrium's electrical pathway. More on this later. It is a similar approach for the ventricular tachycardias. The physician will use the mapping catheter to map the ventricle's electrical pathway and insert the ablation catheter to start ablating. We use two different types of ablation: radiofrequency ablation, which is hot, and cryoablation, which is cold. So radiofrequency ablation are radio waves that are delivered by a special generator through the catheter to the ablation electrode catheter tip. This creates a target lesion or area of damage of approximately 2 to 3 millimeters in size, which is about the thickness of 2 to 3 dimes stacked together. This creates a broad, deep lesion. Cryoablation uses freezing temperatures to damage abnormal conduction cells. The type of ablation depends on your arrhythmia and your physician's decision. For the standard ablation patients, once the doctor determines where the arrhythmia is coming from with the electrophysiology study, he will position the ablation catheter in that area and commence the radiofrequency ablation. While this is happening, you may feel a burning sensation in your chest. Let the nurses know if this is becoming very uncomfortable, because during this part of the procedure, you can receive some sedation and/or pain medication as needed. Depending on the type of arrhythmia, the radiofrequency current may need to be applied several times. For example, in atrial flutter, often you need to have more radiofrequency applications. Once the ablation is completed, there is further observation and testing to ensure that the arrhythmia has been eliminated. Success rate on your ablation varies depending on the type of arrhythmia and your heart's anatomy. For more information, discuss this with your physician. For complex ablation patients with atrial fibrillation, atypical atrial flutter, and ventricular tachycardia, first the doctor will insert a special mapping catheter to identify the electrical pathway in your heart. The images are examples of those special mapping images. For atrial fibrillation, the ablation catheter will be placed in and around the pulmonary veins to block the abnormal electrical impulses. You may require more than one of these procedures. The goal of this procedure is to reduce the frequency and the severity of your symptoms. For ventricular tachycardia, atypical atrial flutter, and left-sided atrial tachycardia, they use the same special mapping catheter to locate the arrhythmia and then ablate and block the problem. After the ablation, the doctor will do several tests to ensure that the arrhythmia is no longer present. When the doctor is satisfied with the results, the ablation is finished. The catheters are removed and a suture will be placed at the puncture site. Then you will return to the day unit. You may be wearing an oxygen mask when you wake up. This will be removed once you are fully awake and breathing well. Bed rest is typically 1 hour when the suture is used to close the groin area. After you are off bed rest, the suture remains in place typically for another 4 hours. 1 hour after your procedure, you can eat and drink when awake. You may bring your own snacks if you have special dietary requirements. While you're recovering, let the nurses know if you have any bleeding or swelling of your groin. Bruising and discoloration is common. When the suture is removed, you will be required some more time on bed rest, and a bandage will be applied to your access site. You will also have an IV removed from your right arm. Discharge checklist. Reviewing medication instructions with your nurse and physician prior to your discharge. It may be helpful to write them down. For atrial fibrillation patients, you will need to continue a form of anticoagulation following the procedure. They usually will ask you to take your anticoagulation prior to leaving the hospital. Activity guidelines. General guidelines are taking 2 days to rest and no lifting over 10 pounds for 48 hours after the procedure. Avoiding stairs, trying not to go up and down stairs numerous times in a day. Also, if you have to go up and down stairs, to lead with a leg on the other side of the puncture site when you do so. If you sneeze or cough, applying pressure to the groin site at the same time for stabilization. After a week, if there's no bleeding or problems at the puncture site, you may resume your regular activities. Make sure you review any specific activity guidelines with your physician prior to leaving the hospital. Driving instructions: do not drive or operate a motorized vehicle for at least 2 days following your procedure. Review this with your doctor prior to discharge because rules vary depending on your arrhythmia, especially for ventricular arrhythmias. Returning to work, again, review this with your doctor prior to your discharge. Generally, if you have a job that involves mostly sitting and no manual labor, you can probably go back to work within a few days. If you work a more active or heavy lifting job, you may be off work longer. Again, consult with your doctor. If you need a medical note, contact the office of your physician who is performing your procedure. What to expect at home: caring for your puncture site. Keeping the area around your puncture site dry for 2 days or 48 hours, and wear loose-fitting clothing for the first few days. Avoid taking a shower or any activities that might get the puncture site wet for the first 2 days. If the bandage gets wet, replace it with a fresh one. Completely remove your Band-Aid 3 days or 72 hours after your procedure. Keep an eye on any signs of infection. Bleeding: if you have a small amount of bleeding, lie down and apply pressure firmly for several minutes over the area where the bleeding is coming from. If the bleeding stops, keep the leg straight and still for 2 hours. If you are not sure what to do, call the Heart Institute and ask to speak to the nursing coordinator. If you have a large amount of bleeding, lie down, apply pressure firmly, and you can call 911. Do not drive yourself to the hospital. Do not have a family member drive you to the hospital. Common sensations or feelings: you may feel fatigued for a couple of days. Take time to rest, and this will gradually get better. You can have some mild chest pains that may worsen when you lie down or take a deep breath. This will subside within a couple of weeks. You may take Tylenol to help with this pain. This mild chest pain should subside on its own. If you are having sudden severe chest pain, seek urgent medical attention. It is common to have episodes of arrhythmia for a few weeks after the ablation, more common for atrial fibrillation patients than other arrhythmias. It can get worse before it gets better. It does not mean that the treatment has failed. It takes your heart 2 to 3 months to fully heal. You can contact your physician's office for further guidance or contact the nursing coordinator at the University of Ottawa Heart Institute. If you're having any severe symptoms with your arrhythmia, seek urgent medical attention. Management zones. This document identifies when you should be calling your physician who did your procedure and when to seek urgent medical attention. Ensure you have a copy of this document prior to your discharge. The yellow zone identifies when to be cautious. If you develop a fever or a temperature above 38 degrees Celsius or 100 degrees Fahrenheit, a sudden increase in swelling or bruising around the puncture site, or the site starts to drain pus. These are signs that you should be contacting a medical professional for further testing. If you are having arrhythmia reoccurrence without any severe symptoms, call your electrophysiologist's office. In the red zone, you need to get immediate medical attention, so call 911. If you're having any episodes of severe chest pain or shortness of breath, weakness or numbness of any of your arms or legs, if you're having trouble speaking or difficulty or painful swallowing, if you start to vomit, cough, or pass any type of blood, if your hand or foot is cold or changes colors, if you have any bleeding that is not slowing down once you're applying pressure firmly, you call 911. Standard ablation follow-ups will generally take place 2 to 3 months from your ablation date. Complex ablation follow-ups, you should be receiving a call from our diagnostic department to organize a 14-day Holter monitor 3 to 4 months after your procedure. The physician's office will contact you with results and to organize a follow-up appointment. Then you will have a repeat Holter monitor 6 months and 12 months post-procedure. If you have not received a call from the Holter monitor after 4 months, please contact your physician's office. Please note that follow-up appointments may vary depending on your condition and procedure. This slide is for important phone numbers. We have the nursing coordinator's phone number. If ever you need any advice, this is available 24 hours a day, 7 days a week. We have the waitlist management questions, and we have the atrial fibrillation clinic if needed.